Good afternoon, everybody. It's a pleasure to see you all again today on Thursday. Today we have Dr.Ann Broderick with us, who will be teaching us about breathlessness and cough. Ann is a palliative care physician from the States. She has been a palliative care physician for over 20 years and is currently the Director of Hospice and Palliative Care Services at the VA Hospital in Iowa. Ann comes to Pallium as a volunteer to work on an annual basis, and this is her 4th year back at Pallium. So we welcome her to teach the session today.
Thank you, Delamie. We're changing accents on you. I hope you all do well with the switch. Right. So let's get started. I'm not sure, have we, this one? To get over to
get to the.
Is that okay? So my topic, which one is it? Is it that one or this one? Oh. Yeah, which one? That's the not the same. Okay. Is this the one? I don't want the picture there. Okay, thank you. So today's topic is breathlessness and cough. I'd like us to stop. I'm hoping that at the end of this talk, we will have you thinking about the mechanism of shortness of breath or breathlessness, not as a symptom, but that you work out the mechanism of why somebody is short of breath. And I urge you to challenge the dogma that you have learned, that you learned 20 years ago, as I did, or that you learned 5 years ago or 10 years ago. And I'll tell you a funny story later in the talk, because I too had to challenge the dogma of how I treat breathlessness. And then I'd like all of you to participate in using your powers of observation, what you see, what you smell, what you hear, to help you understand why a patient might be breathless and to figure out the best therapy. So this can be surprising. I like to think of breathlessness very similar to pain, that we need to stop and evaluate. So to that end, let's start. I am going to ask you all to participate. You may have just had lunch and feel a little sleepy like me. But let's see what you see. What do you see when you see this man? I know I'm using somebody from a US context, but tell me what you see. So don't forget to unmute when you have something to say. Would it be easier if I just called on you? Dr. Bharat, would you like to start? What do you see in this picture?
Sorry, ma'am, I'm not able to comment on any particular finding. What I can just see is a lean, emaciated men.
Okay, why don't you stop there? A lean, emaciated, somebody with cachexia. Mm-hmm. All right.
Yeah.
Yeah. Well, let's let somebody else participate because there are many findings here. So lean cachectic man, Dr. Sorry. Okay. This is why my parents named me Ann, so nobody would have as much trouble. Go ahead. Sorry about that. What do you see?
Patient is with oxygen.
Okay, they're on oxygen.
Yes.
Good. See, it's easier if you're one of the first people. Dr. Bhaja? Fadia? Do you know?
Sorry, I guess he's on oxygen.
Okay, we've already
Obviously.
established he's on oxygen and cachexia. What else?
And chest is
I'm sorry? Do you notice anything about his position? How he's breathing?
Abdominal.
I'm sorry, Dr. Ina?
Abdominal breathing. Prop up.
chest.
Problem breathing. Okay, difficulty breathing. What's the position that he's in?
Prop up with
Right.
backrest.
Okay.
Actually, సర్దం చేయకక్కడే ప్రస్తుతానికి.
Oh, propped up breathing. All right. So sitting up straight. Is he sitting up straight?
Yeah, with the backrest.
With the backrest. What else? Thank you. That'd be helpful. What else do you see? I'm a palliative care doctor, so I'm very happy with silence. Can you see anything else? Dr. Nishu, do you see anything?
I see a pulse oximeter connected.
Okay, there's a pulse oximeter. What else?
He's having a 90 line on his left hand. Some bandage is there.
Okay.
Might be a subcutaneous
Or IV line. What else? I need the picture. Bluish discoloration of the chest wall. Bent forward. Yes. What's that position called? Anybody know? That's a tripod position. And it's the position that we suggest a patient sit in if they're having difficulty breathing. And we'll see why in just a minute. Are there any other parts of the picture? Anything else you see on the picture? I'm going to ask some of my colleagues behind me. Do you see anything about this picture that's of interest? So he's leaning forward. That's causing a change in the dynamics of his chest wall. Cachectic with an oximeter. You may also notice that he has a urinal sitting right on the bed. He can't even walk far enough to go to the bathroom. All his equipment is right next to him. A tripod, T-R, you want to spell this for me? T-R.
Yeah.
Can you?
Thank you, Dr. Broderick.
Thank you. Tripod position. All right. Anything else? And he's clearly lost weight. He has probably either pulmonary or cardiac cachexia. Any other findings? Okay. All right. So we haven't even touched the patient. And what do we already know about him? We know that he has pulmonary cachexia, which is an indication of severe and advanced pulmonary disease. He has what we call a barrel chest. I know all of you know this. We see him in the tripod position because that's the only way he can be comfortable. He's on chronic oxygen. All his needs need to be met very close by because he can't tolerate walking. All right. Well, here's a person in a tripod position. I don't understand this. I can pressed it here.
The slide.
Okay. This person is also in a tripod position. All right? But they've just run a race. They do not have end-stage disease, but they too are working to change the physiology of their chest wall. So lots of people use different physiology to change and different kinds of breathing. You may also have noticed that he used pursed lip breathing because I don't dare to turn this back. Is it just tiny? Do you see his lips with pursed lip breathing? That helps get rid of the air that is trapped by COPD. So the longer, that long expiratory phase is designed to help with getting rid of any trapped air. So, is this working better? Okay, so runners use the same way of changing the physiology of their chest wall. These two are also in a tripod position. They're very short of breath at the end of a race, but this is physiologic and does not reflect that they're in trouble. So I want to try and have you visualize lungs, and I have used a similar picture. I've also used a soda bottle to explain to patients why they might be in trouble. To the point adjustment. Sorry. So this balloon on the bottom represents the diaphragm. The diaphragm is probably the most important respiratory muscle. And when you breathe, it will go down, it will, and when you exhale, it'll go back up. Also important part of lung physiology is the chest wall, which if you have a metastatic lesion to your ribs, can be painful and difficult to move. And in addition, you have, this isn't quite accurate because it's more like a grape-like group of balloons rather than a single balloon, but each one of these is representing left and right lung. So it is helpful sometimes for patients to understand why they're short of breath, and this is a good illustration of that. They could also be short of breath because of head and neck lesions that are outside the chest wall. This also, I have to go back up. This also will illustrate what happens in inhalation with the diaphragm going down, in trachea, bronchus. I know you know all of this, but you might decide that this is good information to draw and illustrate for patients, especially when they have pathology. So again, simply an illustration. I also use a bucket to illustrate, and I don't know if my cartoon is going to work, but if it does, it might be helpful. Sorry, we should have. It doesn't matter. When the bucket handle comes up, the ribs act just like a bucket handle. The bucket handle comes up, the ribs come up. And this illustrates the importance of the intercostal muscles as part of the respiratory muscle. So while the diaphragm might be the most important muscle, you also have intercostal muscles that are moving the ribs and allowing the chest wall to move out and expand the lungs. So breathlessness is, or dyspnea, is a subjective sensation. We as clinicians looking at a patient cannot say that they have dyspnea. We can say that they're breathing fast. We can say that they look uncomfortable, but breathlessness is their sensation. It is what the patient says what it is. And very similar to pain, it's amplified by anxiety. And I have found that just as much of the anxiety of the patient, there is also the anxiety of caregivers and clinicians. So whenever you add anxiety into the setting of breathlessness, it has been completely amplified. Last year, a group of students from the University of Iowa went to visit a patient with very severe shortness of breath. And it was striking to me that visitors, family, and the patient all had so much anxiety that the breathlessness of that patient was completely amplified and made worse, such that the patient had to be moved to our inpatient unit. It is possible that calmer demeanor on the part of clinicians and caregivers is helpful. So for that, I usually recommend the same thing I recommend when you're doing a pain assessment. Which is a chair. Try to sit down and calmly breathe and model slow breathing with the patient. Often will make a difference. I have been known, especially in the emergency room, to ask that the family go get a cup of coffee so that I can slow down the breathing of a breathless patient. It doesn't always work, but it is important that we start by simply showing confidence and competence, and then modeling a slower breathing rate. Like I say, it doesn't always work. I'd like to show you in the next, so this is for our movie, I'd like to introduce you to Jay. He is one of my former patients. He's since died. And I want you to get two ideas from this movie clip. The first is that I want you to look at him and use your powers of observation to see why you think he might be short of breath. Please do not be distracted. He has a cleft palate and a cleft lip, and so that has little to do with why he is short of breath. The other thing I wanted to show you is that here is a patient who, not quite yet, here's a patient who gave me permission to use this slide as a teaching slide in perpetuity, signed a consent, and I think it has high impact to be able to see a real patient who might have shortness of breath. So let's see, don't worry if you can't hear exactly what he has to say, but let's see how this goes.
I work remotely out of my house. I work for a major company, Motorola, in fact. A majority of my tasks are computer related and phone related, so that allows me to work out of my home instead of working out of Chicago.
Mm-hmm.
How long have you lived in Iowa City?
Well, I was born in Iowa City and I lived here for about 27 years, and then I moved to Chicago for my job, and then we moved back about, 2 years ago?
Some of us have never really experienced shortness of breath. Can you just describe what it feels like? Because what sensations you have?
In the really, really, really bad cases, you almost feel like you have to urinate. And it's, I guess would be like you're drowning. You can't breathe, so it's a lot of anxiety. Kind of a lot of adrenaline, because you know you need to breathe. And you just try to breathe and you can't get enough air in, so it's kind of a panic attack also.
Oops, I left him with his mouth open. Sorry about that. So what did you notice? If it's easier to use the chat, please go right ahead. What did you notice?
Patient is dyspneic to complete the whole sentence also. He is not able to complete the sentence.
I think that's brilliant, right. So he's unable to complete a sentence. He's obviously worked hard at that. What else? Sorry, if you're putting something on chat, I don't see it, but anything else?
Maybe he becomes more apprehensive while when he describes regarding the dyspnea, means how he feels. He says that he feels like drowning sensation.
Feels like a drowning sensation. What do you suppose his diagnosis is? Any ideas?
I don't know about the diagnosis, but definitely his functional residual capacity has reduced to below that closing capacity or something.
Absolutely right. Jay, I'd like you to also notice that he's using all of his chest muscles to sort of bring, I don't know if you've noticed that he was rocking and trying to use his muscles and his chest wall, almost going into a tripod and back over and over again. You might be startled to know that Jay was on, at this point, he was on 30 milligrams of morphine twice a day, just to help him relieve his ongoing shortness of breath from his muscular dystrophy. So he had advanced muscular dystrophy and made a decision late to adopt a child, and so decided to have a tube put in his stomach so that he could see his babies grow up a little bit. But he had severe weakness. His negative inspiratory force was quite low, and so he needed to use all the mechanical ability that he could to be able to just get breathing in. And he was BiPAP dependent, so he used he had non-invasive ventilation to help him at night. He did not feel short of breath, even as he was talking to me that day. And he certainly knew what severe shortness of breath would look like. So now I need to go back to the PowerPoint. Yeah, we're done with him. At any time, I'd be happy to show you the rest of the film. I regularly use this film when I'm teaching about shortness of breath with residents and students. Okay. So the causes of why somebody might be short of breath should have been going through your mind at the times that you saw the first patient who was just sitting, a still photo of him. But it also when you were seeing Jay, these are the possibilities. And I'd like to encourage you to stay completely open at all times about why somebody has shortness of breath, because sometimes we make assumptions. And this happened with Jay, for example. At one point, I met him in the emergency room, and I thought that he just was more short of breath because he had progression of his muscular dystrophy. However, he ended up having a pulmonary embolism. So try not to get blinders on where you assume that the underlying condition is still worsening. Sometimes something new can also happen. So let's just, I know you can read, but I'd like to make sure, I hope my spelling is right. It's not American spelling, so I may have not done things right. So, so you could have obstructed airways, either from tumor or COPD, which is an obstructive illness, or asthma. Your volumes may have decreased from restrictive disease, from pneumothorax, lung collapse, and effusions. More stiffness from pulmonary fibrosis. You could also have a decreased gas exchange from pulmonary embolus. Jay was used a wheelchair to get around, and so he was at risk for a pulmonary embolus, but all of us just thought, Jay, your muscular dystrophy is getting worse. Rib fractures, because it changes the whole dynamics of how the chest wall moves, can also make you splint and not breathe completely appropriately. And sometimes patients who get neuromuscular failure from motor neuron disease or muscular dystrophy, but what we don't appreciate, and this is especially true at the Veterans Hospital where I work, we don't appreciate how much muscle weakness happens just with advanced heart and lung disease. So sometimes we put a patient, let's just say that we have a patient with advanced lung disease, and we put them in the ICU and place them on a ventilator and allow a ventilator to help them. They can have so much weakness in their muscles of their chest wall that they never get off the ventilator. So shortness of breath, cachexia, and weight loss and weakness is not just from motor neuron disease. It can also be seen in advanced cachexia. The other two really make good sense. If you have fluid in the alveoli, then it will be harder for you to do gas exchange. And if you're anemic, you may be simply short of breath. You may have developed atrial fibrillation, and that could cause sudden shortness of breath as well as anxiety. Every once in a while, we see somebody who is very tachypnic, but they're not expressing that they're short of breath. It is important to know the difference between somebody who is tachypnic, that is, they have a rapid respiratory rate, and somebody who's breathless or dyspneic. So dyspneic is always the subjective sensation of feeling short of breath. And what's important, this is why I point out that Jay is on morphine. It is interrupting his sensation of shortness of breath, but he is still breathing quite hard and with difficulty. So the assessment, I will always say, requires a chair. If you tower over the patient or show them more anxiety, you are likely to heighten their shortness of breath. So sit down and assess the patient. Before you even saw that man who is cachexic, or you saw Jay, or you would have read the chart and seen what you thought was a possibility. But try not to get blinders on because other things might happen to people. Then, just like you do an assessment of pain, make sure you hear from them what it feels like, what the time course is like, how they perceive it, and whether it's causing them any distress or if it impacts their daily activities. Our first man wasn't even able to walk to the toilet, needed to use a urinal. Jay is walking, working, having a family. He is having a very active life and doesn't have the same impact on his daily activities. I increasingly know that palliative care is treatment of both the patient and the family, but I know this more than anything when I'm treating pain and shortness of breath. These are two conditions that cause great escalation of symptoms for the family. So it is sometimes my role to calm both the family and the patient. I had a fellow who is a junior doctor in our system who typically would start all his pain and shortness of breath assessments with a short meditation. I thought that was sort of gutsy, but it was very effective in calming the room down and showing that he was in charge. All right, so what we try to do is build the history, find out as much as we can from the patient, and then what do we do next? What's the next step? So we've gotten all this history from patient and family, and the next step is to do a physical exam. All right, let's see what we can find on the. Oh, the management will also depend a great deal on where they are in life's trajectory and what they want to be doing. It is true that when we see a patient with rapid deterioration, it is possible that there's a treatable cause. So if a patient is doing okay and then has a rapid change in the middle of the night, then it's possible that we might be able to turn things around, either because they have an infection or because their anemia has become more symptomatic. They have tachypnea because of renal failure, metabolic acidosis from their renal failure. Unfortunately, sometimes there's some things that we do less well with. If a tumor is pressing on an airway, both in the chest and outside the chest, we can try dexamethasone. We can try doing emergency radiation if their lifespan is long enough. COPD and asthma both respond very well to prednisone and inhalers. We try to avoid intubating patients in the intensive care unit because there is so much muscle wall weakness. And always, effusions can be tapped, pleural effusions can be tapped. It may be, however, that a patient is now at home and wants to focus on being with family and not going back to the hospital. This is not unusual for patients just to say, I'm done with going back to the hospital. Do what you can for me in the home setting, but I'm done with tests, needles, blood products, drawing blood. I just want to be here with my family. And even if it's treatable, I'm not interested anymore. So it will be important to assess what the patient and family wishes are for transport to the hospital for any of these therapies. Sometimes we use antibiotics. I caution, especially in advanced cancer, I know there's an oncologist among you, but in advanced cancer, the tumor burden can sometimes cause a fever. And so not all shortness of breath and fever is an infection, but sometimes, especially when the tumor burden is heavy, a shortness of breath can simply be from tumor burden. So treating reversible causes, if it's in keeping with the patient's goals, I hope that means something to all of you, that we don't treat because we can, but we treat in palliative care because it's in keeping with their goals. Sometimes these are even things that we can do at home. Increasingly, we drain ascites in the home. Sometimes we've even had the foresight to put an indwelling catheter in that allows it to be drained on a regular basis. This is also true of pleural effusions. We put a drain in that allows family to do the drains of the pleural effusions. Again, not unusual for us to use diuretic to reduce fluid overload. And if somebody has a rapid, irregular rate and we're in the home, I might also encourage the patient and their family to go ahead and treat the atrial fibrillation because the patient will be more comfortable, even if they don't want to go to the hospital or to the ICU. If the patient is only breathless on exertion, like our first patient who is sitting relatively comfortable on oxygen in that chair, try non-pharmacologic management. Addressing anxiety. I like to say to patients when things are calm, I like to ask them what they fear. Asking patients what they fear will frequently give you a chance to find out what they're worried about and give you a chance as a clinician to reassure them. Similarly, we also need to talk to family and talk about how they can be part of the problem if they spiral with their own anxiety. We now know that patients, especially patients with advanced lung disease, do best with a fan because it moves the air in and around their face. And it's believed that this has a central effect in reducing their shortness of breath. Cooler rooms, learning breathing patterns, both tripod position and pursed lipped breathing have been known to improve patients' tolerance of exercise. In my practice, I send people for pulmonary rehabilitation, which may or may not be a practice here in India, but it involves having them try to exercise to their ability and learn the techniques of tripod breathing and pursed lip breathing to see if they can get more muscles built up that will help them with their shortness of breath. If they had cancer in a certain lung, then we usually have, we determine if they're less or more short of breath with that lung downwards. Okay, so I think I told you that Jay was on morphine, considerably higher doses than this. In part because he became somewhat tolerant. Morphine, I use much lower doses when I'm treating breathlessness than I do pain because it appears that the receptors, the J receptors in the lung, are responsive at much lower doses. It's helpful, especially in my setting, people associate morphine with the very end of life. It's helpful if we introduce it early on for them to use just to see if it helps them with the breathlessness. So it does decrease the patient's sensation of shortness of breath through stimulation of the J receptors in the lung, but it does not cause respiratory depression. I would use this with caution in patients with obstructive sleep apnea, but I have used it very successfully in low doses in people with lung disease. And so morphine should be used in patients at the end of life suffering from breathlessness, not just cancer patients. It is safe for patients in lung failure, heart failure. In the US, where I have more alternatives, I tend not to use morphine in kidney failure, but in low doses, it will certainly be appropriate. Now, patients with dementia, if they develop shortness of breath it's possible to use, especially the liquid formulations, if they have difficulty swallowing. Families who also associate morphine with the end of life will do well to sit down and have explanations. Benzodiazepines can be helpful. They are not the first line agent, and I typically only use that when, as Jay described, you feel like the patient's in a panic attack. You can use midazolam, which is short-acting, under the tongue. Lorazepam is sort of medium-acting, and clonazepam is very long-acting. Using oxygen is a double-edged sword because once you start it, especially in the context of India, and the patient doesn't have the ability to use it at home, you set them up for something that might be more difficult. I typically do not use oxygen unless the oxygen saturations are low. And I always try a fan in a cool room first before I add oxygen in, so that I don't restrict what's possible for the patient at home. In the US, it's very routine, especially from the VA, for people to have oxygen at home, but I wonder if we really need it as much as we use it. When patients are getting asthma and COPD, the first line would be inhaled. However, I'm noticing here in India that people are using salbutamol tablets that you may get some resistance from using inhalers with spacers. I like using aero spacers or spacers because it's more effective and they tend to get more of the effect. And continue to use your preventive inhalers all along. This I borrowed from Delamy. Gives a plan for a family on what to do when the patient gets breathless so that they don't precipitate more difficulty and end up in the emergency room or in an ambulance when they would do better just staying at home. So yep. Okay, thank you. There's a question on the chat. What's the difference between an inhaler and a spacer? An inhaler is the instrument that you use to put in the mouth and press and take a deep breath to distribute the medicine throughout the whole lung. For people who have difficulty coordinating, pushing the button and taking a deep breath at the same time, you can put a spacer which has so you push the medicine into the spacer and then take the medicine at your own level of coordination. So it's an attachment onto the inhaler that allows you it's simply it's simply easier. We routinely use it. Okay, somebody said, Dr. Sunil has said, spacer is a device into which you can push the pump and then inhale from the spacer. All right, well explained, thank you.
I'll send you a photo.
And we can also send you a link of what it would look like. All right, thank you. Thank you, Dr. Sunil.
Thank you, ma'am.
So terminal breathlessness is the term that we give to somebody who is at end of life and appearing to breathe hard, and is voicing that they are experiencing breathlessness. And just as patients shouldn't be suffering with pain at the end of life, nobody should be having difficulty with breathlessness either. Morphine has been shown to relieve breathlessness and should be at a dose. We typically ask the nurses to give that dose that relieves the heaving of the chest, and by that I mean they're using all their intercostal muscles in order to develop the negative pressure to get lungs in. And on occasion, we use a target that they should not have tachypnea over 30 to 35. I use that less because frequently patients have metabolic acidosis at the end of life. They're not distressed by their fast rate. I'm more looking at their faces to see if there's any level of distress. Furrowed brow and moaning might provoke me to give more morphine. However, when somebody starts Cheyne-Stokes respirations, and that can happen, this is a normal finding at the end of life, and families need to be alert to the fact that Cheyne-Stokes breathing is not a sign of distress. It simply means that a lower part of the brain is governing breathing at that point. So, of course, you know the Cheyne-Stokes respirations can be very alarming in the fast phase, and then it almost appears that they're so hypopneic that they might not even appear to be breathing, and then they start again. This is very alarming for families. It is probably not distressing for the patient because the lower part of their brain is governing breathing, and their level of consciousness has now declined. We will share this, I'm realizing that it's getting quite late, so we will share this treatment algorithm, which we designed to try to get everyone to think about mechanism. As you can see on top, it says the patient complains of breathlessness. We want you to assess it, whether any non-pharmacologic treatment can be started, and then assessing whether this patient might have head and neck cancer. I'm sorry, I just need to, let me see if I can get a pointer. Okay, so here I am, you're assessing breathlessness. So you want to treat anything that's reversible. If they have head and neck cancer, it's likely that they're having some kind of intrinsic obstruction that's outside the chest wall. Inhalers are unlikely to be helpful. They may have obstructive symptoms such as wheezing, cough, pursed lip breathing, tripod positioning. That's a person who's going to do well with an inhaler trial. Or they may have cardiac symptoms with peripheral edema, pleural effusion, and history of heart disease, and then you might consider a diuretic trial. Jay, the patient that you saw, is out of all of these, and he has chest wall weakness, and he did well with his morphine trial. We will share this algorithm with you after today's lecture. Okay, so here's where I had to have dogma challenged a little bit. In the US, we have not used theophylline for a couple decades. This is a medicine that is been in use for 80 years. We stopped using it because we saw cardiac and seizure deaths for high doses when it was used as a bronchodilator. Very heavily toxic and required blood level monitoring. It turns out in recent data that there may be a role for low dose theophylline, and this is important in low resource environments. So it may have some anti-inflammatory effects in only two conditions, COPD and asthma, because it inhibits phosphodiesterase and might increase sensitivity to corticosteroids. So the only place I would typically use it is in severe asthma and COPD that's not responding to inhaled corticosteroids and beta agonists. There's no role for theophylline at the end of life. The side effects at these low doses, which is about 200 milligrams a day, is nausea and vomiting. As I said, cardiac arrhythmias and seizures are more common at the at higher doses, and I would not favor those. And I would probably avoid the IV versions of theophylline based on America's history or US's history. I don't know. But I have to thank this lecture for my going back and seeing, challenging my own dogma, because we have not used theophylline for decades in our country. Because the time, I've taken more time than I meant to, I'm going to briefly go through cough. Again, it's not a symptom and not a disease. Use cough as a reason to think about what the possible mechanism is. Don't jump to infection. Don't jump to infection even when there's a fever, because it's important to work out other reasons for cough. Asthma and COPD, you're going to hear related wheezes. Interstitial lung disease and pulmonary edema, there will be lung findings. Probably the most common reason for cough in the US today is gastroesophageal reflux because of our obesity epidemic. Allergies, I'm seeing that a lot here in Kerala, but aspiration, space-occupying lesions, and don't forget about ACE inhibitors. Okay. Are we, anything on that we need to answer? The treatment, dextromethorphan is an opiate analog, but is not a form of opiate, is available over the counter in the US. I have not been able to find it here. It will it is very effective in suppressing cough without any of the side effects of opiates. Low-dose morphine will also suppress cough. Benzonatate will also inhibit cough. Inhaled lidocaine, there are no controlled trials. We use it when we're desperate, as we also use gabapentin when patients have cough that's refractory to opiates and benzonatate. The medicines that I frequently see over the counter in the US and here, guaifenesin and antihistamines, have no data to support their use. These are the three medicines that we have on our formulary here at Pallium India. And as you can see, they're often using combination therapy. The terbutaline plus guaifenesin and menthol we're basically giving beta agonists by mouth. Frequently people feel very jittery when they start on that. Theophylline and its analog etophylline might also be effective at low doses. Again, probably more indicated when the inhalers are either unsuccessful or cannot be afforded. And salbutamol with theophylline, I fear that you're adding side effects together with those. I'd much rather see inhalers if they can be afforded. So my summary is to sit down, think about the mechanism, not just the symptom, treat according to the mechanism, but also the stage of life. What might be appropriate for a patient with early breast cancer might not be appropriate for an elderly person who wants to be at home. And I encourage you to challenge dogma every day of your career. Things that you've been taught need to be challenged, and I encourage you to do so. There are a couple things that I'd like to make sure that you know about. There is a Fast Fact app for palliative care symptoms on, and that's what the icon looks like. And I encourage you to download that as well. So thank you very much. Sorry, I thought I wasn't going to be taking this much time.
We now have an opportunity for any questions or comments before we move on to our case discussion. Okay, we'll go on to our case discussion, and there'll probably be questions that arise from that discussion. Dr. Nishu will present our case discussion today.
Good evening, everyone. We'll be discussing one case. This patient was with us 1 month back. She's a 45-year-old patient who was referred from pulmonology with breathlessness at rest for 2 months that aggravated for the last 10 days. She presented with facial puffiness, left upper limb edema, and she was not able to sleep due to breathlessness. She was sitting and trying to sleep, but she could not lie down. And she also had decreased food intake due to this deficit. She was diagnosed with carcinoma breast with recurrence with lung mets. She was diagnosed CA breast in 2010. She underwent MRM on 27th of February 2010, that is 7 years back. After that, she underwent 25 fractions of radiotherapy and 6 cycles of chemotherapy, and she was under follow-up for the disease from oncology. She presented with tears of 2 months duration in 2017 August, and she was investigated and found to have lung mets. After that, she underwent 10 cycles of chemotherapy, but there wasn't any response with that, and she was referred to palliative care for symptomatic management. When she presented, her respiratory rate was 32, pulse rate was 112, and 94% saturation in her leg. She had facial edema, left upper limb edema, and air entry was decreased over the left side compared to the right side. She had bronchi as well, bilateral. Investigation wise, it shows that CT scan of the chest, diffuse nodular airspace opacities noted in both lobes of the lung, with size ranging from 2 into 2 millimeter to 14 into 12 millimeter. Largest lesion in the right lobe of the liver was in the apical region that had mild, irregular, and speculated margins, possibly metastasis. Chest X-ray showed bilateral lesions which were suggestive of metastasis. The medical college team has done a sputum ASB also, but that was found to be negative, just to rule out any infective cause. Coming on to the psychosocial history, she states she knows about the diagnosis, but she is not aware about the prognosis of the disease. She lives with her husband and a 16-year-old son. Both were supportive and aware of the diagnosis as well as the prognosis. So let's discuss about the management of this patient. How will you manage this patient if you come to see this patient? Am I audible?
Good evening to all. Good evening to all. Ma'am, I am audible?
Yes.
What about chest X-ray finding, ma'am? Is there any fusion? Is there any evidence of pleural chest X-ray and CT chest?
No, there was only bilateral lesions which are suggestive of metastasis. There wasn't any pleural effusion.
Pleura was normal.
Yeah, pleura was normal.
Unilateral limb edema and facial puffiness may indicate to subclavian vein compression because of tumor. So probably an HRCT might help if we are suspecting some lesion on X-ray in and around that area.
HRCT, how is it going to help, sir?
Just to delineate if it's a small tumor obstructing, mechanical obstruction to subclavian vein causing facial puffiness and unilateral limb edema. So if there is a mechanical obstruction, something can be done about it.
Okay, so Dr. Sunil is answering. So
Hello, am I audible?
Yes.
Okay, so we have patient with respiratory distress and the bronchi and the reduced air entry in one of the lungs, but the pleural for pleural effusion. So it is difficult to understand the cause of the facial puffiness and the one edema in one of the arms. Um, did we also note the crepitations? Um, I mean, can we make a suspicion of heart failure?
So no crepitations in the skin.
Probably left upper limb edema, maybe due to post surgery, that lymphedema may be there. So we cannot correlate with facial edema and left upper limb edema as a single cause. So what may be the cause for facial edema, that we don't know.
If the left upper limb edema is also, this is left side CA breast, no?
Yes, probably maybe
Okay,
due to
left side.
lymphedema followed by MRM.
And the reduction in air entry is because of the edema of the chest wall. I mean, is it?
Can we suspect thromboembolism in this patient? Malignancy patient is at high risk of.
Do we have their kidney function?
Yeah. Renal parameters were normal. Creatinine was 1, urea was 30, and hemoglobin was 8.8, and serum protein, total protein was 6, and albumin was 3.1. That was the last investigation that was done before shooting. Suppose you get this patient in a casualty or in your OPD, how will your management start with? You can
Ma'am, is dexamethasone going to be useful in a patient like this to decrease the if there's any tissue inflammation or edema, and could that help for this patient,
Yes.
ma'am? Giving dexamethasone to this patient.
We did start my own.
I think the immediate management has to be supplementation with oxygen, trying to calm down the patient and assist or help him or guide the patient through the process of breathing. And then we should use a rapid acting corticosteroid like the hydrocortisone, and try to reduce the fluid load if at all we are suspecting the edema is because of the fluid overload, and by using the diuretic, and then we can start the opioid need to counsel the patient and the family before starting the opioids. Also use benzodiazepines to reduce of breathing and the anxiety also. So I mean, both opioids and benzodiazepine would also help the reducing the work of breathing, improving the oxygen.
Have we adequately discussed this case?
Patient also has bronchi, so bronchodilator, inhaled bronchodilator is also necessary.
Okay, I'll just brief out the management what we did. When this patient came in, we planned to start her on steroids and then on bronchodilator nebulization. We discussed with the caregivers as well as with the patient and started her on morphine. And on the same day, on the night of admission, we started her injection morphine, injection Dexona. She was not able to take any tablets orally, so that's why we started her on injections on subcutaneous basis, and she could sleep on that night, but she was not able to sleep in spine position. So we discussed with her, and she was in distress also. Though her breathlessness came down, she could sleep that night, but could not lie down, and she continued to be in distress. Hence, we decided to start her on continuous subcutaneous infusion. And after discussing with her and with the caregiver, we started her on injection morphine, continuous infusion, 50 milligram for 24 hours, injection midazolam at night, and injection haloperidol bolus dose in the night. With that, the patient was able to lie down distress-free at night. And
Nisha, please come near to the mic. They can't hear you.
Okay. I'm sorry, I was not audible, I think. I'll repeat the management.
Please go a little slow.
Okay. We started her on injection steroids. She was not able to take anything orally, so we started her on injection. We started her on Dexona. We started on injection morphine and bronchodilators as nebulization. On the day, on the night of her admission, she could sleep, but she was not able to lie down, and she continued to be in distress. Hence, we decided to start her on continuous subcutaneous infusion of drugs. After discussing with her and the caregiver, we started her on morphine infusion for 24 hours, and to reduce her distress, we gave her midazolam and haloperidol infusions in the night. She could sleep that night, and after 2 to 3 days of continuous subcutaneous infusion, patient had relief and she could walk up to the bathroom. She was later on changed into tablets. We changed injection midazolam into tab lorazepam with her and tab morphine also. With that, her symptoms were under control, and she requested for discharge because she wished to be at home with her family. Hence, we discharged her with oral medication.
So was this a classic case of superior vena cava syndrome? It certainly looks like facial edema, arm edema in a breast cancer patient with a right-sided lesion. I think one of you mentioned clavicular occlusion. I think it's just as likely that it was a superior vena cava syndrome. Is that what you're thinking?
Yeah, we were having a doubt whether she was having a superior vena cava syndrome, but there wasn't any engorged veins. And then we discussed with the caregivers also whether they wanted further investigations or further management, but they were very clear that they just wanted a symptomatic management and they didn't want to go for any other further investigation. So we were just managing her symptomatically.
Well done. So it seems like this is a good case of asking the family and the patient their goals and then treating appropriately. Instead of thinking about what we could do, it was having their goals guide your therapy. Well done.
Doctor, I would like to ask your experience patients with cough, say stage 4 or with levodopa.
I'm sorry, I didn't catch the question. Patients with cough.
In lung cancer patients, what is your experience with levodopa?
Which one, sir?
Have you been levodopa? It is mentioned in Oxford textbook of palliative medicine. I was just going through it before this class. So is anybody using the levodopa or Repetus cough syrup?
We are not using it.
Okay.
Can you put it on chat so we can see it?
Yeah.
Thank you.
Yeah, I'll put it.
Oh, there it is. So that looks like we often use that class of medicines with opiates in the form of a syrup, and it helps by having it helps by sedating the patient and helps them achieve some sedation. That's all I can think of just looking at it, but it's in the same. Yeah, but it's not indicated for cough by itself, and I would probably use, I'm not much of a combination drug person, I would just use opiates or dextromethorphan if it's available. Thank you.
We have one more case which Dr. Ann will be presenting.
Mr. Cook will be my support. This is a quick case, but I think what I want it to illustrate for you is not to think in only one direction. So this is a true case of mine. A 58-year-old woman with breast cancer with metastases to the bone at the hip and shoulder and liver. She's currently on anastrozole or Arimidex with good control of her disease by her last CT scan. So she's under ongoing therapy by her oncologist. Her pain is under good control with, these are not available here, morphine extended release, 30 BD, and 15 milligrams as needed every 4 hours. She came to the emergency room with extreme shortness of breath. That's casualty here, sorry. She was placed on 4 liters for nasal cannula. Can everybody else see this, or is it blocked? Okay, I won't belabor this. I made lots of assumptions when I saw her first in casualty and assumed lots of things, probably the same as you are, that this patient had a pleural effusion, a new breast lesion, that she had a new metastases to her ribs. But instead of acting, instead of doing labs, I was with a junior doctor, and so our next step was actually to take more history. Is the chat blocking your vision, or is it okay? So the night before, she had gone to bed perfectly fine. Of course, she had advanced breast cancer, but she was fine. No difference in her symptoms, but she awoke suddenly with severe breathlessness and sat bolt upright. Her husband attempted to slow her breathing and calm her down, but she would not be reassured. He called an ambulance and brought her in. So she also has diabetes and anxiety. What are all of you thinking about right now? Maybe just use the chat.
Panic attack, ma'am. Could this be?
It could, I don't know what you said. It could be a pulmonary embolism? Yes. She has cancer.
No, ma'am. I was saying a panic attack. That's what Dr. Saurabh's put in the chat. A panic attack.
It could be a panic attack. She has obvious history of anxiety. Her husband tried to talk her down. That didn't work. All the other things that I mentioned related. She could have a new lesion that was blocking her airway and causing wheezing. So we examined her, junior doctor and myself. She was extremely anxious. She was upright in her bed, refused to lie down at all. Her husband was pacing in the room, adding to the anxiety. Her respiratory rate was fast. Pulse was fast but regular, because it did occur to me that she might be in atrial fibrillation. Her blood pressure was slightly elevated. She was afebrile. There was no jugular venous distension, and there was no edema of the upper extremities and neck and face. She was dull in both faces, making me think about a pleural effusion. Her heart was tachycardic, but no changes. I couldn't get her to lie down to do any abdominal exam, but she had no edema. Thank you. You're thinking like it could be heart failure because it was an early morning. So somebody's suggesting that we get an EKG and look for ST changes. Her white count was borderline, not very elevated. Hemoglobin 11.8, same as her baseline for chemotherapy. Her creatinine is normal. Dr. Bharat, I'm getting to your request in just a minute. Normal liver function tests. Here is her chest x-ray. I couldn't find the pleural effusion. She had no tenderness on her chest to suggest a new rib lesion. For reasons that probably just because the junior doctor was there, we got an EKG. This is a classic anterior heart attack. For me, this is very humbling, of course, when it's the last thing you think of. We felt very lucky that we got the EKG. She did well. But important for us to remember that people who are 50-year-olds with long-term diabetes can get other problems as well. And women especially don't present to the hospital with a big fist over their chest saying, I'm having chest pain. Women can classically appear in an emergency room with not what we call atypical symptoms. They're just atypical for men. I mean, they're not the same, often not the same symptoms in our environment as they were for men. So I share this because it's embarrassing and humbling. This was the last thing I was thinking of. But I encourage you to think broadly and don't eliminate those things. She actually did very well, and to this day is still living because we got to her quickly enough. So I just thought that was a fun case to shake us up a little bit. Sometimes we're called as the palliative care physicians, but our job is to get them to the ICU and get the assistance that they need. So, okay, a little bit different. Do you have any questions about this case? For me, the other instruction is that panic attack is a diagnosis of exclusion. Everything else needed to be marched through before I give her medicines to calm her anxiety.
We have come to the end of the session. Shall we wind up, or is there any other questions?
Thank you, ma'am, for the presentation. Both the case presentations, it definitely mixed up the entire opinion of how to treat patients.
You're welcome.
It's just like thinking out of the box when you don't be prejudiced with the diagnosis of malignancy only.
I didn't hear. I heard about thinking outside the box, and then what did you say?
Not just confined to the diagnosis of malignancy itself, deterioration. Thank you.
Okay, well, lovely to meet you. Thank you.
Thank you all.
Bye-bye. That was actually good having Sunil up there answering the chat. That was a good plan. Yeah. Nice.